Welcome, MRCOG candidates. We're jumping right into a super high-yield, exam-focused explainer of the RCOG Green-top Guideline No. 70 on bladder pain syndrome. So let's dive straight into this official guideline. We're going to nail down the exact evidence-based practices you need to master, not just to crush your exams, but honestly, for your future clinical practice too. Okay, today we're building a mental algorithm using a clinical pathway framework. We'll hit defining and assessing BPS, diagnosis and differentials, initial conservative management, oral and intravesical therapies, advanced therapies, and wrap up with BPS in pregnancy. It's basically a step-by-step roadmap tailored for instant exam recall. Section 1. Defining and assessing BPS. Right off the bat, lock this highly testable demographic stat into your brain. Bladder pain syndrome is 2 to 5 times more common in women than in men. This is one of those classic epidemiological facts that examiners just love throwing into multiple choice questions. Now, the preferred definition here comes straight from the American Urological Association. The really crucial point, the duration. We're looking at pelvic pain, pressure, or discomfort that lasts for more than 6 weeks. But here is the absolute key for your exams, the golden rule. This has to be in the strict absence of infection or any other identifiable causes. Moving on to Section 2, diagnosis and differentials. For initial baseline investigations, you've got to step through a very logical sequence. First up, a 3-day bladder diary to track fluid input and output. This helps you gauge the severity of those storage symptoms. Second, get a food diary to catch any dietary flares, things like coffee, citrus, spicy foods. And third, a urinalysis. Ruling out a UTI is an absolute prerequisite here. Actually, a quick side note, if you see sterile pyuria, you should definitely consider testing for chlamydia and ureaplasma too. So BPS is famously a diagnosis of exclusion. That means you literally must rule out conditions like UTIs, malignancy, and endometriosis before making the call. And here is a massive exam trap. Bladder biopsies and hydrodistension are explicitly not recommended for confirming the diagnosis. Sure, a cystoscopy might be used to exclude other conditions if you suspect a focal lesion, but it doesn't confirm BPS on its own. Do not fall for that distractor when you're staring down those investigation options. Okay, Section 3, initial conservative management. Look, patients often want a quick fix, right? But you really must focus heavily on lifestyle modifications for a solid 3 to 6 months before even thinking about escalating. We're talking dietary changes, specifically dodging caffeine, alcohol, and acidic foods, because those are notorious for triggering flares. Recommend stress management and regular exercise too. Patients frequently report that being a huge help. For the pelvic pain itself, stick to simple analgesia. Paracetamol, ibuprofen, that sort of thing. And whatever you do, don't overlook physical therapy. Internal massage for pelvic floor trigger points is actually backed by solid level B evidence. The whole idea is to keep the patient's overall quality of life right at the center of your care plan. Next up, Section 4, oral and intravesical therapies. Now, if a patient fails those initial conservative measures and ends up referred to secondary care, oral amitriptyline or cimetidine are your absolute go-to first-line pharmacological options. Both of these are backed by level B evidence. Keep in mind, amitriptyline is usually started at a really low dose and then carefully titrated up. Why? Because patient compliance can take a massive hit from side effects like dry mouth, constipation, and sedation. And as for cimetidine, it's actually an unlicensed treatment for this condition in the UK, so it really should only be started by a clinician with special expertise in BPS. Okay, let's map our intravesical options directly to their evidence levels. This is a matrix you absolutely need to memorize for your exams. It's like a cheat sheet. Lidocaine, hyaluronic acid, and botulinum toxin A, or Botox, all sit firmly at level B. Meanwhile, dimethyl sulfoxide, or DMSO, is sitting down at level C. Honestly, knowing these exact evidence levels is exactly what sets a top candidate apart from the rest. Listen closely to this next part because exams absolutely love to test outdated practices. You must firmly avoid prescribing oral hydroxyzine. It literally has level B evidence against its efficacy. And here's a surprising one, oral pentosan polysulfate, or PPS. This is a drug historically associated with this condition, but it now has level A evidence showing it just doesn't work, plus it carries severe adverse effects. Just avoid it entirely. Also, definitely steer clear of long-term antibiotics and high-pressure, long-duration hydrodistension. That high-pressure hydrodistension carries a really severe risk of sepsis or even bladder rupture, so the risks just massively outweigh any potential benefits there. Section 5. Advanced Therapies and Surgery. So, what about patients who are still refractory? Well, these advanced steps absolutely mandate a multidisciplinary team, or MDT, approach. We're typically talking about involving a pain clinic here, and these treatments are reserved strictly as last-line options. If Hunter lesions are spotted on a cystoscopy, cystoscopic fulguration or laser therapy is actually highly effective, which is great because those lesions usually do not respond to oral treatments at all. Other options on the table include neuromodulation, like posterior tibial or sacral nerve stimulation, and low-dose oral cyclosporin A. And then there's major reconstructive surgery, like a cystectomy with urinary diversion. But remember, that is the absolute last resort for severe, totally unmanageable cases where literally everything else has failed. Finally, Section 6, BPS management in pregnancy. This is a really critical clinical question, and honestly, one you're highly likely to face in an OSCP or a written paper. What exactly happens to a woman's BPS symptoms when she becomes pregnant? And more importantly, how do we safely manage her pain while protecting the fetus? Well, the crucial point you need to know is that symptom severity during pregnancy is completely variable. I mean, it could improve or it could get significantly worse. It's a bit of a wild card. When it comes to treatment, you have to stick to safe options like oral amitriptyline and intravesical heparin. Heparin is a safe bet because it's a large molecule, making it highly unlikely to cross the placenta. On the flip side, you must strictly avoid DMSO. It's known to be teratogenic in animal studies, so it's a huge no-go. Oh, and if your patient happens to have a sacral nerve stimulator implanted, that must be turned completely off for the entire duration of the pregnancy, simply because we just don't know the effects it might have on the fetus. By mastering this tiered pathway, starting from strict exclusion criteria all the way up through conservative, pharmacological, and advanced management, you are completely primed to ace your MRCOG exams. But beyond just passing the paper, I want you to consider this. Bladder pain syndrome is a diagnosis of exclusion that can absolutely devastate a patient's quality of life. As medical guidelines inevitably keep evolving and we continue to strip away older, ineffective treatments like oral PPS, how will you balance strict, evidence-based safety with a desperate patient's need for relief? Take that thought with you into your next clinical rotation.